Thanks everyone for joining us at Medical Grand Rounds. Just a reminder to please keep your questions till the end and enter your questions in the chat. As well, please answer a brief survey that will be sent to you immediately after the presentation. Before the introduction of our speakers, I just want to take a moment to make a brief land acknowledgement. McGill University is on land which has served as a site of meeting and exchange amongst Indigenous people. We acknowledge and thanks the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. I'd like to ask Dr. Marcel Baer, the Chief of Infectious Diseases, to please introduce our two speakers today. Marcel, are you able to take the floor?
Yeah, thank you, Nadia. Thank you, everybody, for attending. And thank you especially to Sapha and Marina to agreeing to present. Very briefly, when you're thinking about doing clinical research, you want to have the kind of partnership you're going to be hearing about in the next 45 minutes or so. Sapha is an assistant professor of infectious diseases and medical microbiology. She's trained in also in tropical diseases, and she's currently teaching in, among other places, in Lima, Peru, in the Gorgas course. And in the Division of Infectious Diseases a few years ago, she was elected by the members of the division as the sort of the what do we call it, the master, but that's gender incorrect, the clinician par excellence for her ability to manage complex care and to show up every Friday rounds with some of the most obscure and crazy diagnoses and often be shown to be right. When you partner Sapha's energy as a clinician and her expertise with Marina Klein, you have with Marina Klein a Tier 1 Canada Research Chair, National Co-Director of a CIHR clinical HIV trials network, who's served on International AIDS Society Governing Council and is also, among other things, leading Métropole Sans Hep C, a community-focused program at eliminating Hep C. You can see this incredible strength we have, and they're going to put that in how together they worked on diagnosing, managing, and responding to the Mpox outbreak last year. So thank you, Sapha and Marina. We look forward to the presentation.
Thank you so much. Thank you for this very kind introduction. We're very happy to be here today to present about our experience, Mpox outbreak in Montreal, a model for responding to emerging epidemic. So, sorry, I'm just gonna. All right, just like so here are our disclosures. So the objective of this talk, I'm just going to remove this down. All right, the objectives of this talk are to understand the epidemiology, clinical presentation, management, and prevention of Mpox, recognize the importance of community engagement in responding to public health threats, identify the key ingredients needed to implement a rapid response to an emerging epidemic, and finally, appreciate the value of local, national, and international collaboration, knowledge exchange, and research to catalyze epidemic control. So we are about 1 year ago already, time flies, it's May 2022. May 13, more specifically 2022, the United Kingdom notified WHO of 2 laboratory confirmed cases and 1 probable case of Mpox. All 3 cases belong to the same family. There's no travel history. The index case had a rash on May 5th and was admitted to London Hospital on May 6th. He was transferred after to a specialized infectious disease center for ongoing care, and Mpox was confirmed on May 12th. So May 18, just a couple of days after, I'm on call for tropical medicine, and I receive a call from one of my colleagues who wants to discuss a case. This is a 32-year-old man who has sex with men. He's on HIV, well controlled. He had a recent travel to Florida and returned early May 2022. He reports 7 to 10 partners in the last 4 weeks. He developed anal pain 1 week before presentation, followed by papules, then pustules on the arm and cheek, and developed also a sore throat. So there's a PCR gonorrhea on the anus that is done and came out positive on May 17. So the question was, could this all be like gono? Is it a gonococcemia? Or, we've heard about these new cases like of Mpox reported in Europe. Are we seeing a case of Mpox? So, of course, given this differential diagnosis in mind, we really wanted to make sure that everybody was safe, and we evaluated the patient in a negative pressure room with airborne and contact precaution, N95, gown, gloves, face shields, everything. And because we had in mind this could be Mpox, but this could also be varicella. So as we were seeing the patient, we were kind of trying to learn at the same time, how do we collect specimen? How do we make a diagnosis of Mpox? So we went ahead and collected 3 vesicles, unroofed the vesicle top, and used a flux swab, put that in a universal transport media, double bagged, called the microbiology lab. We may have cases of Mpox. We called the public health lab. We may have a case of Mpox. It's coming within 24 hours. And call also the Direction de la Santé Publique to notify that we maybe are seeing a case. So the day after, May 19, appel à la vigilance, Direction de la Santé Publique de Montréal. Éclosion de lésions ulcéreuses génitales et buccales d'étiologie indéterminée à Montréal. So they basically, since May 12th, had 15 declarations of lesions that are genital and oral lesion. And what they noticed is that all those cases were on men who have sex with men. And so because of the context, the epidemiological context, and the cases that were reported elsewhere in Europe and even in the United States, we wanted to make sure that, we're not missing something, and those cases may definitely be Mpox cases. May 20, 2022, the day after, we have an infectious disease meeting with infectious disease and medical microbiologists. We're all the team together, and we're thinking something needs to be done. We need to have different working groups taking care of clinical management, laboratory testing and biosafety, infection prevention and control, as well as research, because we need to learn more about this disease. So there was a lot of question at that time. So how do we recognize a case? What are the clinical features? How do we make a diagnosis, and how do we manage and treat? And even, is there a treatment? What are the specimens that we should collect? What transport media? What else should we order? Who will be tested? And what are the biosafety measures? In terms of infection prevention and control, what PPE should we use? What do we know about the transmission of Mpox? And how do we isolate a patient? And until when do we isolate the patient? Who should we notify? And importantly, also, how do we prevent cases? Is there a vaccine? And in terms of research, a lot of questions. Who gets the disease? How and why? What's the natural evolution? And what is the viral kinetic? What's the immune response? Who should be treated and how? And what is the vaccine effectiveness, if there's any vaccine that we can use here? And of course, there's all this importance of communication, because you really want to be able to accurately inform the general population. You don't want people to get scared, but you want people to have the right information. And things are moving very fast. And I think we all know that now we have the COVID-19 experience. Also, we want to avoid stigma, given that there's like a specific affected population. So we went ahead and we had many interviews with the media and tried to explain what was going on to the general population. And also rapidly, we put together guidelines to be able to manage a suspected case of Mpox that was coming to the MUHC. So we worked hard and put all this together very, very quickly. This happened within less than a week. And of course, the patient is at the center, but also collaboration is at the center for all those aspects that I already discussed. In terms of clinical management, there's local, national, international, the medical community, the public health, CDC, ECDC, all those organizations that were putting together guidelines. In terms of laboratory, we had to work with our hospital lab, but also the biosafety committee and the provincial lab, and also the Canadian National Microbiology Lab. Also, in terms of infection control, we worked very hard with the infection control here in the hospital, but together with Public Health, Quebec, Canada, but also the Comité d'Immunisation du Québec, and also the Canadian Immunization Committee to be able to have indication for the vaccine. And in terms of research, we get together and we collaborate. Of course, we're going to discuss about the MI4 CRP platform, and we had national and international collaboration, and also with media, social media, webinar, publication, community engagement to be able to communicate very well our findings. Rapidly, we became like at the MUHC, a little bit like the chef d'orchestre, the center of many clinic and hospital around us who were also seeing cases, and we would reach out to them and they would reach out to us saying, oh, I have a case, I have 2 cases. And so we decided that we're going to put our efforts together and we're going to put our case together and try to describe the case and better understand what's the clinical presentation of the disease and what's the epidemiology. So I'm going to discuss a little bit about the clinical presentation. So the Mpox is a double-stranded DNA virus from the genus Orthopox that also include, as you know, variola, vaccinia, and the cowpox virus. There's 2 clades, clade 1 and 2, but formerly called Central Africa or Congo Basin clade. So that's now the clade 1, and the West African clade is now called the clade 2. And in the clade 2, there's 2A and 2B, and the current outbreak is within the clade 2B, the lineage B.1. And there's a difference between those 2 clades, that there's as you can see, a geographical difference, but also a difference in mortality, the clade 1 being associated with a higher mortality rate compared to the clade 2. So there's different possible transmission. So the one that we're going to find more in endemic country is from animal to human transmission. It's unclear now exactly what is the reservoir. It's still unknown, but we think it's probably rodents. And it's from really manipulating those animals, for example, hunting, and then manipulating the animal, or just getting bitten or scratched by the animal, or in contact with blood or any biological product from the animal that the disease can be acquired. From human to human transmission, the current 2022 outbreak is really predominantly human to human transmission, with, as you will see later, most of the transmission being sexual contact. So it can be acquired with direct contact, with skin lesion, mucosal contact, also droplets, and vertical transmission. And also you can have contact with objects that were contaminated, and percutaneous inoculation that was reported, for example, in healthcare worker with needle injury, and they had lesions where the percutaneous inoculation occurred. There was recently also cases reported of tattoo and piercing, so needles from tattoo and piercing contaminated with Mpox, and then lesion where the tattoo and piercing were. So that was recently reported in the New England from Spain. Also, there's a question about could we see pre-symptomatic transmission? And so that is still an area under research. It's not quite clear, but there's some modeling, modeling that showed that it may occur up to 4 days before the onset of symptoms. So this is a nice scheme that show the different mechanism for spread depending on the way of transmission. So you can see in the 2022 outbreak, you can see that, and we're going to discuss about it in the next few slides, that a lot of individuals had mucosal involvement, oral and genital involvement, and anal involvement. And so from there's viral excretion and from the perineal lesion, and with sexual contact or close contact, dermal inoculation. And then there's primary lesion and there's replication. And you have the antigen presenting cell that get infected and that go to the lymphatic system. And then you usually had probably little replication because we saw very few clinical other lesion and a mild rash in those sexual contact. However, in certain situations, when you have more extensive replication to the lymph nodes, then the viremia may be more important and you may end up with a more generalized rash in certain situations, for example, an immunocompromised individual. And of course, respiratory droplet is a mode of infection and usually end up into extensive replication in the lymphatic system, including also the spleen, the liver, and then may end up with a more generalized rash. So the incubation period is 7 to 17 days, usually around 7 to 10 days. And there's a prodromal phase with fever, fatigue, lymphadenopathy, malaise. And this is followed usually the usual presentation, followed by a rash that goes from macules, papules, vesicule, pustules, and then umbilication, crust, and scabs. And then it resolves in about 3 to 4 weeks usually. In certain cases, you can see a complication, less than up to 40% of cases with either secondary bacterial infection, diarrhea, encephalitis, corneal scarring, and vision loss. And depending on the clade, 1 to 10% of death, but you can see in our situation here, it was less than 1%. But in this current outbreak, the features were a lot different from what we used to see. And we would see, first of all, a more localized lesion at the oral or genital or anal region, as well as the prodrome is present, but it can appear after the rash happens. And also very few lesions in the skin were seen compared to what was usually seen in endemic country. And the majority of cases were among men who have sex with men. So here, I'm sorry here, I should have warned you before this picture. Sorry for those who are eating their sandwich. So don't take the next bite. Here I'm showing you lesions, different lesions that were seen in our patients. And those, you could see here, umbilicated lesion here on the penis that eventually will form a crust. And this is the evolution over time. You can see also ulcerative lesions, so a lot of genital involvement, but also oral involvement with edema, throat. I'm going to show you pictures later. Sometimes very few lesions with one here and there, very small. This one is a very cute umbilicated lesion, ulcers, and also you can see just small vesicles. So you see that there's really different presentation. And what we've seen also is that lesions can be in different stage in one single anatomical site. So what was not the usually seen with this disease. So everybody we put ourselves together and we collaborated with many countries all over the world, including European countries, South American, in North America, of course, Israel, and we reported the greatest and the biggest case series of cases of Mpox, and we described the clinical picture and the epidemiology, and that really helped us to understand better the disease. Here I'm giving you some example of oral and perioral lesions, so you can see that the different clinical presentations. So the index of suspicion needs to be very high to be able to make the diagnosis, because it can mimic many different infectious and non-infectious diseases process. And here you see example of perianal, anal, and rectal lesions, sometimes with very severe prostatitis and patient experiencing very, very severe pain and distress. So transmission in this current outbreak is 95% sexual transmission, and most commonly in male, for 98% that we've seen in male. HIV positive really overrepresented, around 40% were HIV positive. Most of the cases were non-serious cases. There was about 5 to 6% hospitalization, depending on the different series, and the death is much less than 1%. Now I'm going to discuss a little bit about the epidemiology. So here it's just a timeline to give you a little bit an idea of what happened since 1970. So 1970 is the year where it was first described in a human. It was described in a 9-year-old baby who was not vaccinated for smallpox. He was the only one in the family not vaccinated for smallpox. And then after this case was described, a couple of other cases were described and reported. So throughout the years 1980, 1990, and most of those cases at that time were reported in young children. And this was probably because those young children were not vaccinated against smallpox. An early epidemiological study determined that the protection, if you were vaccinated for smallpox, you had about 85% protection against Mpox. And that's where those data come from those early studies in the late 1980s, beginning of 1990s. And then what happened in beginning of 2000, so in 2003, there's the Mpox situation came to the world, because now there were cases in the US. And why? It's because there was imported animals, Gambian rats, that were imported in the US and infected prairie dogs who themselves infected humans. So there was about 71 probable cases, 35 confirmed cases at that time. And if you look in PubMed at that time, you have like a raise in the number of publications. And then it went down again, and people stopped thinking about it, but it was still going on in endemic countries. So there was waves of outbreaks in endemic countries, 2005, 2007 in DRC, and then 2017, big outbreak in Nigeria. And they had no cases for 40 years, and then they had a big outbreak in Nigeria. And then from 2018 to 2021, there was cases reported in non-endemic countries such as UK, Israel, Singapore, from people who traveled from endemic countries. And then, of course, we saw an increase of cases from December 15, 2021 to May 2022. We saw an increase of cases in the endemic countries such as DRC and Nigeria. And it's in May 2022 that we saw this major outbreak. So as of about February 2023, there is more than 85,000 cases in more than 100 countries. So here, just to give you an idea, most of the cases are in North America, South America, Europe, a lot of cases there. But you can see that in every region, it had plateaued over time. In Canada, as of March 17, there were about 1,500 cases, and most of the cases are in Quebec and in Ontario. And here I'm showing you an image from a publication that we had. I'm going to show you the publication later, but it's just to show you that in terms of the phylogenetic tree, the lineage is really from the outbreak are really all concentrated or almost all concentrated in B.1. So what, in terms of prevention and control, so what can we do? So we have vaccination, and the vaccine Imvamune is the one that we have here in Canada. It's the equivalent of Imvanex in Europe and Geneus in the United States. It's a third-generation live attenuated smallpox vaccine incapable of replication. And it's produced in orthopox-modified vaccinia strain Ankara Bavarian Nordic. So you can give it in pre and post exposure, and it's 2 doses that are usually given 1 month apart. So here are the indications for vaccination in our setting. So this is from Quebec Public Health. So in post-exposures, so somebody who is exposed to a case of Mpox should receive the vaccine ideally within 4 days of exposure, but it can go up to 14 days, but the shorter, the better. In terms of pre-exposure, public health had put together a list of people that are at increased risk, and those people could go and get the vaccine. So we were very lucky to be able to work in team and collaborate with all the clinics and the lab and the public health lab and the Public Health Montreal and the Canadian National Microbiology Lab to put together the experience in Montreal of Mpox. So you can see here that the decrease, the very nice epidemiological curves here that we all like to see, with the vaccine starting in the post-exposure vaccine, started at the end of May. So we were very quick in Montreal to start vaccination. And at the beginning of June, we started the pre-exposure vaccination. And that is because we realized rapidly that it was very difficult to do the contact tracing because a lot of the contacts were anonymous. So we were not going to make it with just post-exposure vaccination. So we launched very quickly pre-exposure, and the uptake was very good in the community. And the work that was done was amazing. And not just the vaccine, of course, but, a combo of public health measures made this curve go down, as you can see here. And so now the questions are, what's the vaccine effectiveness? So that's one of the questions. And so I'm showing you those data that show that if you have 2 doses of vaccine, you have around 70% vaccine effectiveness. And for partial vaccination, so just 1 dose, it's quite low. It's around 40%. So I'm going to let Dr. Klein discuss about the global response. Sorry.
Thanks so much, Sapha. I think your enthusiasm and excitement about how this epidemic hit us in Montreal, we were one of the probably first areas, certainly in Canada, North America, to really appreciate what was going on. And it was happening at a time where we were just coming off the back of very intense time of COVID-19, as you can imagine. So just as we were sort of settling down and trying to take stock of what had happened with COVID-19, suddenly this new emergency came. And I think the fact that we were able so quickly to acknowledge it, appreciate it, and act on it in Montreal turned out to be quite a beacon for the world in the initial days. And I'm going to talk a bit about that now. So one of the, I think, key things we have to recognize is it took quite a long time for the WHO to recognize COVID-19 as a potential pandemic virus, but things turned around a little bit quicker with this time. And I think it was because in large part they were sensitized to how immediate and quick action is really necessary to contain things. Although at the beginning of this epidemic, we were seeing one particular community highly affected by Mpox. There was, I think, an underlying concern that this could spread beyond this community and then could really cause a tremendous amount of difficulty for other populations, which might be less readily accessible to prevention measures. So on July 23rd, the WHO Director General declares that monkeypox, as it was called then, and I'll talk about the name in a moment, was an outbreak of a public health emergency of international concern. And what does that mean? That actually frees up a whole bunch of different mechanisms to start to address this, that money can flow and collaborations can flow right around the world. And the timing turned out to be quite interesting for us because here in Montreal, we were hosting the first International AIDS Conference that occurred face-to-face since the pandemic occurred. And so only 2 weeks later, and this is Jean-Pierre Routy, who was the local co-chair of the meeting, about over 10,000 people descended on Montreal, HIV care professionals and members of civil society, including people from all over the country. More than half the delegates were from low and middle income countries, despite the fact that we had issues issues around visas and getting people here. And it was really a time that we could showcase an approach. And this other picture here is a special session that was integrated into the program sort of at the last minute to address issues around Mpox. And you can see on the stage actually a representative from Montreal Public Health, that's Geneviève Bergeron, who is with us in the Annals paper, myself and Dimitri Daskalakis, who was at the time the director of the Center for Disease Control in the US on the HIV prevention and response. And he comes from a background of advocacy actually in the LGBTQ community, but he was in a bit of a shock as he presented the CDC's response because during that same panel, this is what occurred. And this, I haven't seen, being at a lot of AIDS meetings over the years, such a response in terms of advocacy and in many, many years. And I think there was a lot of anger that had built up around the lack of a response in the United States, in which we saw in the end, it wasn't maybe so clear on the graphs that Sapha showed earlier, but really they had a disproportionate number of cases, you know, sort of similar to COVID, whereas in Canada, we managed to contain things quite rapidly. It took quite a long time in the US. And part of that was because they sort of sat on their heels for a little bit. They didn't have the same vaccine available to them. One of the lucky points we had was that Canada had acquired the Imvamune vaccine as part of its response potentially to any smallpox bioterrorism event. And so we had actually stockpiles in the federal reserves of this vaccine that could be and was fortunately rapidly made available to provinces to put out public health response, which a little different situation in the US. But this meeting, as well as a lot of the other picture there is a press conference that went on for about an hour around, you know, what do we need to do to address this? And it really turned a tide, I think, particularly for the United States. Indeed, the availability of the vaccine in Montreal became a global news and other news outlets feature for several days as tourists were coming here to get vaccinated, as we opened the door and allowed anybody to become vaccinated. It also highlighted the approach to vaccination, which wasn't just making it available, it was the community engagement. It was setting up vaccines outside in the gay village with flexible hours on nights and weekends, and really just to try to make this as accessible as possible. So really something. But I think we have to also acknowledge that there's still a lot of inequity in the world regarding vaccination, very similar to what we saw with the COVID-19 pandemic. Countries that received the Mpox vaccines in 2022 are all in high-income countries, and only no vaccines were delivered or allocated to low and middle-income countries. And as a consequence, we see very few deaths in the high-income countries, and a disproportionate number of people who are affected and dying, even though they had smaller numbers of cases in developing countries, in Africa in particular. I'll just turn just briefly to the name. I think Sapha illustrated that it's since 1970 that we recognize this virus. And its name comes from the fact that it was first identified and worked on from a monkey that was infected. But this is not thought to be the animal reservoir, but that name stuck for many, many years. And given the potential for this to be stigmatizing, not just to the animal, but to the, you know, the consequence of what, where the region of the world that monkeys come from, the people who could be affected by this, there was really a concern that this was not an appropriate name to be used. And through a series of consultations, the WHO came to the name of Mpox, which is what's now being used and phased in over the next year. But in fact, Réseau, one of our community partners here based in Montreal, a group that works with LGBTQ plus communities, had pushed this name since the very beginning, and we had started using it at that point. And they actually made a petition to the WHO, so we can hope that they can partially take credit for this particular name being chosen. Now, I'd just like to turn to some of the many unanswered questions that we have, and certainly don't have time to go into all of them, but I think that really spur us and make us excited about trying to continue to do research in this area, because although we saw this tremendous response with the epidemic curve coming down, and we have very few cases circulating at the moment, at least in North America, I think we're all agree that this virus has not gone away, and it's going to continue to evolve, and with us as a society, we need to be able to address it going forward. So we can maybe partition these questions into several boxes, and here I've just laid them out. What are the predictors of disease severity? Although this clade that is currently behind the worldwide epidemic is one that's not been traditionally associated with high mortality, I think you'll see in a moment that we're starting to get some inklings about what the immune system can do to prevent us. What are the best approaches for treatment and prevention? As Sapha alluded to, we really need more data on vaccine effectiveness. 1 dose versus 2 doses. How did people who have prior smallpox immunity do? Is the vaccine, does it prevent infection or just prevent severe outcomes? Does it change the natural history of the how it will present? And will we miss new cases in vaccinated people because the presentations are less severe? Why did Mpox drop off so quickly? I think we've been attributing this to the public health measures, but I think it's probably very likely more than simply the vaccination, and there's probably a lot to do with how behavioral change occurred in various communities who were very sensitized to this quite dramatic infection, which had a lot of pain and suffering for a lot of individuals, even if it doesn't have a high morbidity mortality. And finally, what is the future epidemiology of this infection? Will it just become another sexually transmitted infection that we have to be concerned about? We've seen hugely rising rates of syphilis and other STIs in the last 10 years. And adding this to the mix is going to complicate matters extensively, especially because of the long period of time people remain infectious and have to be off work when they are infected with this virus. Will it spread to other populations? Will it establish new animal reservoirs? We have some evidence that this can happen, and I think this is something that we really have to keep an eye on. And how best do we go about monitoring this epidemic going forward in terms of what types of surveillance can there be? We've learned from COVID-19 quite a lot, and we're already using wastewater samples to monitor for Mpox in Montreal currently, which I think is an example of transfer of knowledge from one epidemic to another. So I'm going to show some pretty dramatic pictures now, even worse than those that Sapha already showed us, but this is giving us some information about disease severity. So this is data that comes from the same kind of group that put together the New England Journal article that we previously presented, looking at the manifestations of Mpox in severe and immunosuppressed HIV persons. And what we can see is that much more dramatic outcomes with highly ulcerative lesions, confluence, even verrucous looking like lesions, but even worse, I'm trying to get this, go ahead. Here's a particularly illustrative case in someone who is very immunosuppressed with a CD4 cell count of 13, not controlled HIV virus, very high viral load, who despite receiving tecovirimat, which I will discuss further, the one antiviral we think has promise for this infection, went on to progress and unfortunately died. So he developed initially anal and rectal lesions, lesions that were very similar to those that we've seen in other cases, but these continue to worsen and affect multiple mucosal areas. But most strikingly, this person developed large nodules in the lung. These were actually biopsied and shown to contain multiple viral inclusions, and unfortunately succumbed finally to fatal bowel perforation. So this is just one dramatic response example, but looking across the various cases that they reported, we can see that there's strong association between the level of immunosuppression and high viral load in terms of the case fatality rate, with almost 30% of those who were very immunosuppressed dying from this infection. So this group and this presentation has really led to a call for adding Mpox to the list of opportunistic infections in HIV. And you can see, in the developing world or in low and middle income countries, who may not have ready and stable access to antiretroviral therapies, how this virus could really be quite important. So moving to discuss treatment, We do, fortunately, because the virus has been around for almost 30, 40 years that we've known about it. I mean, it's been around a lot longer than that, but aware that it's could be a potential pathogen for humans. There already was quite a lot of information and understanding about the viral life cycle and what are potential targets for drug development. And indeed, we know that existing drugs act at various points of this viral life cycle already. So cidofovir and brincidofovir, which are two drugs that were really developed for treatment of CMV disease, will interfere with DNA replication. And tecovirimat actually is important in inhibiting assembly of the viral particles and release into the extracellular virus and can prevent infection. Indeed, tecovirimat and cidofovir both show activity in vitro against Mpox, but tecovirimat looks more promising because it's active at nanomolar concentrations as opposed to micromolar concentrations. So it's really been this drug that most have focused upon. It's an oral antiviral drug that was developed by SIGA Technologies, which is a very small biotech firm in the United States, and it was really designed for smallpox. And so they have this kind of bioarmor portfolio of drugs where they're really focused on bioterrorism. And it turns out that they've sat on this, a golden opportunity, but they're a very small company and didn't take this forward to develop into human trials, both because they were focused on smallpox, and we can't do human trials in smallpox. It targets the VP37 protein, which is highly conserved in all species of orthopox viruses, which is why it does have activity against Mpox, and it's been shown to do so in animal models. And fortunately, it does not appear to have a high potential for toxicity because it's not got any mammalian homologs. Phase 3 trials have demonstrated a reasonable safety profile in healthy volunteers. And among many case reports now, we have confirmed that this looks to be a safe drug. Its efficacy, on the other hand, I think still remains to be shown. There are some hints from early case series that there might be activity. So this is from the very first Lancet series of cases from the UK that Sapha described earlier. But for example, here with no tecovirimat given, a very long period before the virus drops in the upper respiratory tract and in the blood. This is one case where they show initiation of tecovirimat seems to be associated with a relatively rapid suppression of shedding of the virus, as well as a quicker resolution of the rash. This other patient receives brincidofovir, and there's a safety signal here. So it's another reason why this drug is probably not going to go forward, and with a very high level of transaminitis. But one very concerning thing, and I think particularly because we want to be using such a drug in the context of very severe cases, in the case series that I showed earlier, there's laboratory confirmation of resistance occurring in 3 of 5 people who were tested who had severe immunocompromise and disseminated and progressive symptoms despite prolonged treatment. So they had 2 courses of more than 14 days of tecovirimat, and these patients finally died. So I think this is something that we really need to keep an eye on, because it may have limitations in the setting. And something similar to the fact that we saw with COVID-19 is that where are we going to develop resistance mutations? It's going to be in immunocompromised patients and where there's high viral replication with no immune control. So I think we have many questions that remain about how effective this drug can be. Will it improve the time to resolution of symptoms, virologic clearance, prevent complications? Can we get around this issue of resistance? Currently, it's only available to us for severe cases and hospitalized cases in Canada. That's not true everywhere, though, in the world. And we really need to know if there's a role for mild to moderate disease or the prevention of severe cases in vulnerable hosts. So there's clearly a space here for randomized trials. And this was recognized very early and very quickly by the National Institute for Health and Care and Research in the UK, who, if you look at the date here, on the 30th of May, so very shortly after the first cases were determined, issued an urgent call for funding in monkeypox research. A month later, they had received and reviewed and decided on a team to lead this work. and this is the Platinum study. This is the same group that led the COVID-19 recovery trial. And I just want to point out the fact that they funded this trial to the tune of £3.7 million. And the drug was also secured, both the drug and placebo were secured from the SIGA for this. They managed to get up, running, and recruit the first patients by August 2023. So very rapid when there is clear investment. We also saw the need for a study in Canada for two reasons. One, because we wanted to contribute to the global understanding and the response for this virus. And we were seeing large numbers of cases at the time and thought this would be important, but also be able to provide a means of accessing tecovirimat for other participants who would not be eligible to receive it because of disease severity in a way that could be assessed objectively in a trial situation. So we reached out to the Platinum group, understanding that in Canada, we were going to have a smaller number of participants likely, and we probably could not ever achieve a fully powered trial. And they were very open. We had lots of discussions. We finally came to the decision that we would not be a site of their study because it was too complex to work that out, but that we would develop a parallel trial with the same primary and secondary objectives. And this would permit us to perform an individual patient meta-analysis by combining our data at the later date. And this is the route that we took because it was the most expeditious and seemed to be the best for it. But I'll just contrast the timeline of our study with this timeline I just presented before from the Platinum study. So we had the idea around exactly the same time. In fact, we got together a group of people, particularly through the Canadian HIV Trials Network, and developed a protocol very rapidly. So by mid-June, we had a full protocol. And then we had to find funding. There was no funding coming from above. We had to find funding from below. And through a series of consultations, negotiations, and discussions with the Public Health Agency of Canada, which we thought would be the people who should be supporting this, we finally arrived at a directed research call, which came in July, which was but it was not to fund a trial, which is what we've been sort of advocating for. It was to fund efficacy data in drugs, it was to fund vaccine effectiveness and the natural history. So everything. And all that for $500,000. So you can see Canadian, which you can see, we finally ended up convincing them that we would try to do two of the three and not all three. And that vaccine effectiveness really required a full set of different types of people involved and different methodologies. Suffice it to say, we finally secured some funding to get the trial underway in July. And at the same time, we're working with SIGA to negotiate drug supply, which we also achieved. I'll have to say we submitted all these protocols for ethics review way early in this whole process, but we didn't get our final ethics review until sometime in October. I'm just putting the epidemic curve in the background here. You can see how cases are falling off dramatically. And so by the time we were in a place to open this trial, there really was no longer any active cases in Canada. And indeed, we still haven't got ethics approval at all of our sites. We did initiate at the MUHC and actually screened our first participant last week, whose screen failed because his lesions had already cleared up and he had been vaccinated. So it just goes to show you that we may see a different situation in the new time. There are other trials out there, but just to point out that they face some other challenges. So this is another example of like high level support and through the NIAID funded AIDS clinical trials group, a 500-person trial recruiting from 80 clinical sites, got up and running very quickly. In the United States, tecovirimat is available far more easily. So they've had almost no success in recruiting anybody because they couldn't get it open label and not participate in a placebo-controlled trial. So it's going to be difficult to actually get the answer to these questions for a variety of reasons. Indeed, it's just now that the Food and Drug Administration of the United States has come out with guidance about how these trials need to be conducted. And I think people at the beginning were sort of hoping we could just jump from the animal model right into humans and get approval. It's quite clear now that we can do these trials in theory for ethically. And so that I think it's going to get harder to do trials, especially as there's no major incentive unless a large pharmaceutical company takes up these drugs and takes up this mantle to push these things forward because of the intensity and the amount of resources needed to actually conduct these trials. So I'm just going to conclude by looking at a few future directions and give some thoughts about where I think some of the lessons we've learned in responding to this epidemic. First of all, it's been a tremendous time to bring together people to work together in partnership. This is a grant that was just funded from the CIHR, which is really subjective to have a partnership between Canada and Africa. And I think this is really important because we have to continuously push to ensure that we're not just focused on ourselves and really help to build capacity, to learn from each other, because both endemic and non-endemic countries are going to face Mpox issues going forward. And so this is a large team grant that was funded. Daryl Tan is a nominated PI. He's based at the University of Toronto, but we also have nominated PIs from Nigeria, and we're really moving forward to look at a number of objectives. There's a lot of other collaborations that have arisen out of this whole work. Clearly, WHO has had an important convener role in bringing together people to, meet about the name, about providing an atlas of a really diverse atlas of all the different ways these lesions may present. So it's been a great exercise to be involved in some of this work. Together with the Oxford group, we and the STOMP group, the trials, we have a working group now to develop an individual trial meta-analysis for all the Mpox trials, because no trial is going to meet the recruitment targets in the near term for the variety of reasons I outlined before. And then there's a number of CIHR team grants that have now been funded that are going to help to look at surveillance strategies and immunogenicity, and people here at McGill, including Cecilia Kosteniak, are leading these grants. And finally, one of the things that we realized at MI4 CRP is really the need to be able to respond rapidly to help support research in the area of all emerging diseases. This came out of COVID-19, but was really put for, a spotlight on during the Mpox initial response, and need to be able to reach participants, collect samples and data, and not have to develop entirely new protocols and a entirely new ethics process each time, so that we can start to collect stuff while on the fly as things are emerging, because otherwise we're really not going to be able to address things quickly. And so this was really a collaborative effort with a lot of input from the REV, modeled a lot on what's been done in previous biobank efforts, like at the Montreal Neurologic Institute. And I think we've come together with Don Vin, who led a lot of the work on biobanks and COVID here, with a document that is going to be a legacy item that I think will really facilitate collaborative research here at the MUHC. So if you want to learn more about it, please reach out to us and we'll be happy to talk about it. So finally, I just want to close by saying, I think the lessons learned is that we clearly, especially in Canada, where there's no top-down kind of emphasis on addressing pandemic research, the fact that we had great leadership on the clinical side, on the research side, a lot of expertise within our group, community engagement that was early on and critical, and strong collaborative networks that really came together to address this stuff, allowed us to respond quickly, and I think had a meaningful impact both for the people who were affected by this as well as for the research community. The problem is we have a lot of missing things that we need if we want to be able to react going forward. I believe that we're really missing a kind of permanent infrastructure that can mount a clinical trial and research immediately whenever a new event occurs. And this is going to take a concerted and long-term investment to ensure that's in place. We have to move forward on common ethics reviews and consents. It can't be that each time we have a new infection or new problem that 6 different REBs across the country have to tear apart a consent form for a trial that is relatively straightforward. This has to be moved forward. It's something we've talked about for clinical trials in this country for years, and this really has to get better. There has to be pre-established commitment from the public health agencies and the government around pandemic issues, and so that funding can flow rapidly when it's needed, and it can be done so in a transparent way. And I think the UK has a good model. I don't know all the details, and I'm sure there's people living there who will criticize aspects of it. But if you just see, contrast the response both to COVID-19 and to Mpox, you can really see a model for perhaps how we should be doing things differently. So in conclusion, I think Mpox is yet another warning to us. We really are not prepared. I think we were lucky, and in addition to really taking lessons that we had learned from HIV and COVID-19 to adapt them rapidly to a public health response, where we clearly engage with community and international collaborators. But governments and funders and the public health agencies were really slow to react, and were cautious and didn't want to move, and didn't want to worried about one population or another population or a group of researchers, and it just stymies things. And there's so far too many hurdles that remain for us to be able to advance knowledge in a timely way so that we can change policy and practice quickly. And with that, I'd just like to close by thanking you for your attention and for all the many people who are behind this work and our funders. I'm sure there's other people here that should be mentioned, but we tried to be as inclusive as possible. And it's really happy to answer any questions.
Thank you so much to both of you, really, for outstanding rounds and for your work done. Really, really fascinating topic. I think I'm going to ask, if there's any questions, please enter them in the chat. We don't have much time. Marcel, I'm going to ask you to unmute if you want to make any comments, please.
Sure. So while we're waiting for questions, I just want to make one comment. I recently read a lay book called The Premonition by Michael Lewis. He's also known for Moneyball and The Big Short. And it describes in great detail how the United States was not prepared for a pandemic in March of 2020. And I echo some of Marina's points towards the end of the talk, but I think she also illustrated how we're much better off than we were in March of 2020, and we're still learning. We can do better, but the work that was presented here in the Grand Rounds has taught us a lot about how we can do better. Now I'm seeing some questions. I'm going to see if I can trace them here. We have, do we know the proportion of people who receive 2 doses versus 1 dose? I have impression the second dose was shadowed by COVID waves. Does anybody want to take this?
Yes, so so what we did initially is that we wanted, because there was a stockpile, but there was not so many vaccines. So we wanted to, a little bit like COVID, we wanted to optimize the first doses. So we started really with the first doses. The second doses were open for people to receive as of October 6th. But the uptake has been quite low. I think like with the outbreak coming down, the uptake was quite low for the second dose.
Thank you. There's a comment here by Ariel about a podcast on CBC regarding the LGBTQ community and the global response to HIV/AIDS in the early 1990s, and has a hyperlink there. So that can be offered as a comparison to what Marina described from this summer. We have a question. Any idea what proportion of cases have DGX? I'm terrible with 3-letter acronyms. And I'm always afraid in a bilingual province that I'm using the wrong 3-letter acronym. Charles, could you tell us what DGX is so that we answer the right question?
What proportion of cases have we diagnosed?
Oh.
Okay.
Any estimate from seroprevalence studies? Have they been done yet?
Yeah, that's a very good question. So for now, there are studies looking at only the infected individual, looking at their serological response. So this is done with the group of Andres Finzi at CHUM, and so they're validating an assay that is not so sensitive, has a good specificity, but not so sensitive. But we're not yet in Quebec. We're not yet doing. We're not yet at the step of doing seroprevalence studies. But it's definitely something that will come up in the near future.
Yeah, I think it's fair to say that there's probably a wide spectrum of presentation and low, possibly symptomatic, slightly asymptomatic disease, and there's clearly spread as or transmission potentially even before symptomatic disease. So I think obviously, like everything, we're undercounting. Yeah.
There's a question about, has there been any response by the RB to make an effort in the future? And the parallel or the twinned question is, how is the UK ethics different than ours?
Yeah, so for the RB, I mean, not to put all the blame on their side, they took the protocol in quickly, and understanding that there was an emergency going on, they did, the first phase went fast. The problem seems to get bogged down at the multiple revision stages and the consent and that sort of thing. And as the kind of pressure was coming off, because there was much less Mpox around, I think it lost momentum. It lost momentum on all sides. But in the UK, for the trial that they did, that it affects all NHS sites. So it just had to happen at the high level, and then all NHS sites could participate. Where here we had to do individual REB submissions. Even within our own province, we have to do individual, even for the multicentric, you still have individual boards that have to take their time to accept it. So there's just too many levels of review here. Yeah.
Great. It looks like it's 1 o'clock, and I imagine the chair of the session is going to close it down. So I'll hand it over to Nadia.
Thank you so much. Thank you, everyone. Wonderful, really wonderful lecture. We'd love more like this. It's great to see a team coming together like the two of you had. And I echo, what the presentation of you that Marcel said at the beginning. I think it's wonderful when you see people in the institution coming together like this. So I wish you continued luck and success with all your work and continued collaborations. And thank you for sharing this with us today. I wish everyone a wonderful afternoon. Thanks. Bye-bye.